BioChange is a regenerative medicine biotechnology company focused on actually helping the body to repair and regenerate damaged tissue naturally. We all know that, in our body, tissue regeneration is actually it's a challenge. And if we are looking into actual tissue regeneration, there is our body do not have the capability as adults to self-assembly the complex organs once it's damaged. So there is a great unmet need that we are actually focusing in trying to give an answer to enable our body or adult bodies, animal bodies, and animal tissues to repair themselves. So the way we actually give our technology answer to this unmet need is by VetFoam, which is a platform technology. It's a biodegradable and biocompatible protein-based scaffold designed to create a three-dimensional environment that supports cell growth and tissue healing. We call this technology the VetFoam, and the VetFoam platform works by mimicking the body's natural extracellular matrix, or actually the embryonic phase extracellular matrix, which is the matrix that holds cells and allow the structure of the tissue and the communication between cells in each and every tissue in our adult body. And
I'm on a webinar.
And also, of course, in the embryonic body or in embryonic tissue. It has been shown that there is a great difference between the embryonic extracellular matrix and the adult extracellular matrix. And part of the ability to regenerate actually lies on those differences. So in an adult extracellular matrix, we have the fibrous structures, very rigid, that actually limit the capability of the tissues to regenerate, because it limits the capability of cells to communicate between themselves. On the other hand, if you look at the left picture, you will see that the embryonic extracellular matrix is a foam-based structure. This foam structure actually enables the communication and dynamics environment in the extracellular matrix of embryos. And in BioChange, I'm not going to go into this, but there are several articles about it in Nature, very, very interesting. But in BioChange, we actually mimic those structures that enable much more communication between cells in tissues. So this is actually the basis of our proprietary technology. We are the only company that design and use scaffolds that are foam-based and mimic the embryonic foam structures. And this is why our platform actually allows and enables a much higher tissue regeneration. And this is actually what we call it. We help nature do what it knows best. So we are our platform technology actually supports tissues to regenerate like they did in the embryonic phase. Thank you. And now I'll give the mic to Hilla, and I'm sure Hilla will explain to you how she uses our technology. And enjoy.
Hello, everyone, and thank you for joining this technical webinar. Today we're focusing on a critical aspect of lower urinary tract intervention, the application of advanced biomaterial for managing canine urethral sphincter mechanism incompetence, or USMI. So as specialists, we're frequently confronted with cases that fail traditional medical management or where long-term pharmacotherapy introduces unacceptable risks or owner compliance issues. And the focus of this talk is mostly procedural. We will dive straight into the underlying biomaterial science, patient selection, a detailed step-by-step preparation protocol, and the cystoscopic injection technique required to maximize clinical efficacy while maintaining minimizing complications. So USMI remains the most prevalent cause of urinary incontinence in adult spayed female dogs, affecting up to 20% of spayed females. And the underlying pathophysiology involves multifactorial decreases in resting urethral tone. And our primary medical choices, namely alpha-adrenergic agonists like PPA and estriols, are highly effective first-line treatments, but they have documented limitations. And approximately 15% of these patients exhibit refractory disease or developing an absolute resistance over time. Furthermore, chronic medication introduces risks of systemic hypertension, behavioral changes, restlessness, and GI distress, alongside the lifelong financial and compliance burden on the owner. So when medical therapy fails, or if contraindicated, we historically faced a steep therapeutic escalation toward invasive surgical corrections, such as artificial urethral sphincter placement or colposuspension. And endoscopic bulking agents offer a crucial, minimally invasive alternative. By submucosally expanding the urethral wall, we can artificially increase the mucosal coaptation pressure, thereby restoring passive resistance to urinary flow without open surgery. Okay, so what is VetFoam? Moving on to the biomaterial science. What exactly is this VetFoam? This agent is composed of highly purified medical-grade porcine gelatin that underwent a modification allowing for enzymatic cross-linking at the point of care. From a mechanical standpoint, when the gelatin polymer is combined with its dedicated enzyme solution by rapid mixing, it initializes a cross-linking cascade, and this process creates a stable, porous, three-dimensional tissue scaffold. What makes this unique compared to older generation bulking agents is its initial consistency. It is injected as a low viscosity foam, which ensures low extrusion forces through the highly restrictive long cystoscopic needles. So once deposited into the submucosal space, it transitions into a stable matrix that serves as a scaffold. Rather than acting merely as a permanent, inert space-occupying material, this porous scaffold permits cellular infiltration, host fibroblast migration, and microvascularization. And over time, the material undergoes control and enzymatic degradation via native collagenases, and theoretically, the artificial foam bulge is replaced with a localized deposit of native organized fibrotic tissue. And this allows for a durable clinical effect even as the primary material degrades. So let's look at this data from a clinical study we've published in the DVM on 2019. The study evaluated 15 client-owned female dogs diagnosed with confirmed USMI that were refractory to or experienced side effects from medical therapies. And following a single injection procedure, complete continence was successfully restored in 13 out of these 15 dogs, representing an initial clinical efficacy rate of 87%. And the mean duration of continence achieved after this single intervention with VetFoam was 11.1 months. It is important to look at the statistical spread though. While some dogs required a reintervention near the 1-year mark, a subset of patients maintained durable continence extending to 21, 22, and even up to 36 months. Regarding safety, adverse events were notably rare and self-limiting. Only one dog out of the 15 experienced post-procedural lower urinary tract signs, specifically mild strongyria and pollakiuria, which completely resolved within 48 hours without major intervention. And this safety profile compares very favorably to historical data on older bulking agents. Case selection. So proper case selection is important to achieving these high success rates. Bulking agents will fail if your primary diagnosis is incorrect. So first, you must definitively rule out all congenital or acquired anatomical abnormalities. This includes specifically ectopic ureters or severe pelvic bladders. A bulking agent cannot compensate for an ectopic ureter that bypasses the proximal urethra. Second, we must differentiate primary sphincter weakness from detrusor instability or hyperreflexia, the classic urge incontinence. So patients with detrusor instability experience uninhibited bladder contractions during the filling phase, and injecting a bulking agent in these dogs will not solve their incontinence. Instead, it can severely exacerbate their clinical signs by introducing a mechanical outlet obstruction against an already hyperactive bladder. And third, a current urine sediment analysis and a bacterial culture are important. If a urinary tract infection is identified, it should be fully treated and resolved with appropriate antimicrobial therapy prior to bulking agent injection, as performing a submucosal injection through an actively infected mucosa carries a risk of enucleating pathogenic bacteria directly into the deep urethral tissue, leading to mural abscessation, necrosis, or even systemic bacteremia. Equipment. So let's transition into the surgical suite and review the exact equipment required for this procedure. So the entire setup must be maintained in a strict sterile field. Our primary visualization tool is a high-quality rigid cystoscope, typically ranging from 1.9 millimeters to 4 millimeter outer diameters, depending on the patient size, housed within a continuous flow irrigation sheath. The VetFoam kit contains the primary biomaterial component and syringes. We have the powder syringe, which arrives sealed inside a protective aluminum foil pouch. And next is the wing syringe, also referred to as the inject aid syringe, which features agronomic finger-winged design to handle the high manual pressures sometimes needed during a high-density injection steps. And a standard lure-to-lure lock connector is included to join these syringes together during the mixing phase. We will talk about it soon. And we utilize a dedicated flexible injection needle passed directly through the working channel of the scope. Specifically, we're using the bony 1.77 millimeter needle from Coloplast. And this needle is engineered with an optimized stiff distal tip and a precise bevel profile, allowing you to puncture the dense, slippery urethral mucosa reliably without causing tearing or premature shearing. You will also need a bag of sterile saline, which is warm to 37 degrees Celsius. And finally, try to have another person to help you. This procedure requires a 2-person team. One is dedicated to stabilizing the scope and ensuring the needle bevel remains perfectly positioned within the submucosa, while the second person is managing the sterile field, mixes, and executing the steady high-pressure injection of the material. With the VetFoam preparation, so moving on to the technical protocol for material preparation, this is where absolute precision directly dictates the mechanical quality of your foam. First, the operator preparing the kit must wear sterile gloves and handle all components within the sterile zone. Before opening any kit, ensure your sterile saline bag has been pre-warmed to exactly 37 degrees Celsius. This thermal control is crucial for both irrigation and mixing. Gelatin solubility and the kinetics of the enzymatic cross-linking reaction are highly temperature dependent, so you must avoid injecting if the scope or fluid temperature drops below 25 degrees Celsius, as the material will set prematurely or fail to form the required homogeneous microporous structure. So the first step is carefully open the aluminum outer packaging and extract the dry powder syringe. Step 2, slightly loosen the red protective cap on the tip of the powder syringe, but do not remove it completely yet. Gently retract the plunger back to the 4 mil mark. This introduces controlled volume of air into the chamber, which is necessary to fluidize the contents. Step 3, invert the syringe and gently tap the barrel several times with your finger. Your goal here is to visually confirm that any packed powder aggregates or microclumps are completely broken up and free-flowing. Then slowly advance the plunger back up to the 2 mil line, and this leaves a clear 2 mil dead space of air above the loose powder. With step 4, completely remove the red protective caps from the prepared powder syringe and immediately attach the female-to-female lure lock connector directly onto the tip of the barrel, ensuring a tight, secure connection. Step 5, you now have a stable, uncontaminated powder syringe assembly ready to interface with the liquid carrier phase. Step 6, take the second syringe, the specialized finger-winged syringe, and introduce it into the pre-warmed 37 sterile saline bag and draw up exactly 2.2 ml of fluid. It is vital to measure this volume accurately to the decimal line. Altering the liquid to powder ratio will significantly modify the physical characteristics of the final foam. Too much saline will yield a low density, highly watery foam that lacks structural integrity, and too little saline creates an overly dense paste that cannot pass through the needle. So ensure all macro bubbles are purged from the saline syringe before moving to the next phase. The final preparation steps. So we now approach the most time-sensitive phase of the procedure, and this requires a full coordination between both operators. Once the liquid and powder phases touch, an irreversible cross-linking reaction begins, and under standard operating conditions, your total working window from the very first plunge to the final submucosal deposit is approximately 7 minutes. So if you delay, the foam will harden inside your syringe or needle, rendering it completely useless. Therefore, do not mix the material until the primary operator, the one scoping, has already advanced the rigid scope into the patient's urethra, identified all relevant anatomical landmarks, and placed the bony needle directly into the working channel, positioned immediately adjacent to the intended first target site. Step 7. Once the primary operator confirms readiness, thread the saline filled wing syringe directly into the open side of the lure connector attached to the powder syringe. Crucially, you must hold the entire connected dual syringe assembly completely horizontal. Do not tilt it vertically. If tilted, dry powder will drift prematurely into the neck of the lure connector and form a dense plug before the saline can pass through smoothly. This will cause immediate structural failure of the mixing mechanism. So now let's break down the exact mechanics of the mixing routine, which is split into 2 distinct mechanical phases to ensure a completely homogeneous outcome. Phase 1 is the wetting out phase. To begin, firmly push the plunger of the saline filled wing syringe completely forward, driving the entire 2.2 ml volume of warm saline straight into the powder syringe. This immediately floods the powder bed, and then phase 2 is the stabilization phase. Immediately after the initial full displacement, push the plunger of the powder syringe back in, but only halfway into the liquid chamber. We will now repeat this limited halfway mixing stroke exactly 4 times. This specific introductory sequence prevents unwetted powder clusters from being forced under high pressure into the narrow channels of the opposite syringe plunger, which would cause systemic jamming. So it ensures every single microparticle of gelatin polymer comes into the uniform contact with the aqueous solvent before we apply high shear forces. Once the 4 introductory halfway strokes are completed, we transition immediately into the high velocity homogenation phase. So now we push the plunger completely back and forth, utilizing full-length rapid strokes between the 2 connected syringes continuously for exactly 30 seconds. This high shear mechanical action folds the entrapped air volume directly into the cross-linking hydrogel matrix, resulting in a uniform microbubble foam configuration. And then after exactly 30 seconds of rapid stroking, execute your final plunge such that the entire volume of the foam is fully captured in the winged syringe. At this stage, stop and wait. This is a mandatory 5-minute maturation period. And place the syringe down on the sterile table. During these 5 minutes, the enzymatic reaction advances to an optimized point, transforming the watery foam into highly cohesive, stable hydrogel network. And once the 5 minutes have elapsed, uncouple the wing syringe from the lower bridge, and the material is now perfectly mature and ready for immediate deployment. The injection technique. So now let us dive into the technical execution and anatomy of the injection procedure. The patient is placed under general anesthesia in either lateral or dorsal recumbency. The vulva and perineal region are prepared aseptically, and the rigid scope is gently advanced through the vestibule into the urethral lumen under continuous warm saline irrigation, which is not usually what we use when we do cystoscopy, but we want the foam to be in the right consistency, so we're using warm saline. So first advance the scope into the urinary bladder to perform a comprehensive survey of the local landmarks, identify the ureteral openings and the bladder trigone, and once oriented, slowly retract the scope distally into the proximal urethra. Your primary target zone for injection lays exactly 1 to 1.5 centimeters distal to the bladder trigone. Do not inject directly at the trigone, as this can distort the ureteral orifices or lead to upper urinary tract outflow obstruction. Once positioned 1 to 1.5 centimeters distal to the trigone, advance your bony needle out of the working channel so it's fully visible on your monitor, and orient the needle bevel facing inward towards the lumen. Approach the urethral wall at a shallow, relatively acute angle, approximately 15 to 20 degrees relative to the mucosal surface. And then advance the tip through the mucosa with a single smooth movement. If you encounter high rubbery resistance, you have probably penetrated too deeply into the urethral muscularis layer. If the needle slips out immediately, you're too superficial. When you're correctly positioned within the submucosal plane, the needle will glide smoothly and sit stably within the tissue layer. To create an effective passive pressure barrier, it is recommended to perform a circumferential series of injections, creating 3 to 5 distinct bulges around the perimeter of the lumen. So a single large injection site will simply push the urethral lumen to one side, leaving a wide crescent-shaped gap where urine can still track through really easily. So instruct your second operator to begin injecting the matured foam with low, steady manual pressure. As the material enters the submucosa, you will observe a smooth, pale, well-demarcated bulge raising into the lumen. You continue injecting at that first site until the apex of the bulge visibly reaches more or less the midline of the urethral lumen, and then retract the needle, rotate your scope approximately 90 to 120 degrees, and repeat the step. And then your final procedural endpoint is a clear and objective, a complete visual mucosal coaptation. And this means that when all 3 to 5 bulges are fully formed, they must physically meet and press against one another in the center of the lumen, creating a closed, star-shaped or cloverleaf configuration that completely occludes the lumen from view. Now we have a video of the injection procedure. Moving on to the second bulge. You can see we're moving circumferentially. We're making a third bulge now. And our last fourth bulge for this procedure. A little bit of bleeding is normal. If there is severe bleed, it's not dangerous. It just sometimes block the view. So we need to stop and wait for the bleeding to subside, and then we can continue. So after injection, we want to, the urethral mucosa is highly elastic and under baseline tension. When you finish forming a bulge and pull the needle straight out, the high pressure inside the submucosal pocket can drive the liquid foam backwards through the needle track, leading to a loss of bulge volume and material wastage. So to prevent this, once you stop pushing the syringe plunger, leave the needle tip completely stationary inside the bulge for about 10 to 30 seconds. It kind of depends on the consistency of the foam before taking out the needle. So this pause allows the hydrogel matrix immediate surroundings to stabilize. And if you retract the needle and observe any material escaping from the puncture site, then immediately bring back the needle directly over the hole and press it against the urethral wall for another about 10 seconds, and usually this will stop the leak. Okay, finally let's talk about the potential side effects. So the most common side effects are mild transient dysuria and stranguria, occurring in approximately 10 to 15% of cases. So we need to tell the owners that ahead of time that mild straining is normal and self-limiting. But we can also sometimes uncommonly see complete urinary obstruction. So if I look at the dog after the procedure, if it has normal or even if it strains a little to urinate, that's okay, as long as I can see it can pass urine. But if the dog is obstructed and does not resolve within 1 or 2 hours after the procedure, then sometimes we do need to insert an indwelling catheter for about 24 hours. Usually it will be a 6 to 8 French catheter. And then we will leave it for 24 hours, take it out, look at the dog. Most of the times it will be able to urinate at this point. Other or routine post-operative medications are usually unneeded. If a dog is pollakiuric and it does not resolve after about 24 hours, then we can use NSAIDs for 3 to 5 days. And systemic prophylactic antibiotics are not indicated unless there is an unresolved underlying UTI that was diagnosed prior to the procedure. And I think that's all I have. Thank you for your time and your comment and your commitment to evidence-based interventions. I would like to open the floor for any technical questions or other questions. And that's it.
Thank you, Hilla.